Before Lisa, like when I was in training, we would intubate babies, we'd put them on the ventilator for hours or days or sometimes weeks until their respiratory distress syndrome got better. With Lisa, we can do in and out surfactant really quickly while they maintain themselves on non-invasive ventilation, so it's been a real game changer. Studies have shown that less invasive surfactant, or Lisa, may decrease the incidence of bronchopulmonary dysplasia as compared to traditional strategies where you would intubate the baby and put them on a mechanical ventilator. You may see this technique referred to as minimally invasive surfactant therapy, or MIST, or catheter-based surfactant. They're basically the same thing as Lisa. When thinking about patients who would require Lisa, they're typically premature infants with respiratory distress syndrome, and the goal would be to perform the procedure within their first few hours of life. To identify patients with respiratory distress syndrome who would benefit from Lisa, we rely on X-ray findings as well as clinical indications, including respiratory support with CPAP, oxygen levels greater than 30%, and elevated CO2 levels. We would not want to use Lisa in a patient with a pneumothorax or in patients that we think would need long-term mechanical ventilation. Another technique that you'll see used is called INSURE. INSURE stands for intubate, surfactant, and extubate. This is different than Lisa. With INSURE, we leave the endotracheal tube in the trachea for minutes to hours after the surfactant is administered. When preparing your equipment to perform Lisa, there are a few things to consider. The first is personal protective equipment, including gloves. The procedure is performed with a 16-gauge angiocath with a 5.25-inch needle. As you prepare the catheter for insertion, you'll want to place a small piece of tape to the catheter to indicate your insertion depth, and a measuring tape can be used to determine that location. An important safety measure is to remove the stylet or needle from the angiocath before use. Once the needle is removed, the end of the angiocath can be bent to a 30 to 45 degree angle, which is sometimes helpful to advance it through the vocal cords. To confirm correct placement of the catheter in the trachea, we use a 2.5 or 3.0 endotracheal tube Y adapter and an end-tidal CO2 detector. These can be inserted into the end of the angiocatheter. To begin the procedure, the patient should have an orogastric tube in place, and stomach contents should be aspirated. A suction catheter should be available in case secretions are encountered. The infant can be swaddled if they are vigorous to avoid interfering with the intubation. For Lisa, you'll need surfactant available. You can use a surfactant of choice at your institution and have it drawn up into a syringe at the appropriate dose. For intubation pre-medication, we typically begin with atropine to stabilize the heart rate and avoid bradycardia. This may be followed by a sedative medication, such as fentanyl. As we begin Lisa, the infant is typically on nasal CPAP, which can be maintained throughout the procedure. A timeout is performed, and then video laryngoscopy is used to obtain a view of the glottis. You'll perform the 4-step technique for blade insertion. Step 1. Look in the mouth to insert the video laryngoscope. Step 2. Look at the screen to visualize the glottis and the vocal cords. Step 3. Look at the mouth to insert the catheter. And Step 4. Look at the screen to visualize the catheter advancing through the cords. The angiocath is advanced through the vocal cords to the depth indicated by the tape marker. At this point, the Y adapter with the CO2 detector is attached. Color change on the CO2 detector confirms correct placement in the trachea. If no color change is observed, we reposition or confirm placement under video laryngoscopy. Throughout the procedure, the infant should continue to breathe spontaneously and maintain oxygen saturations. CPAP pressures and FiO2 can be adjusted as needed. To administer surfactant, connect the syringe to the hub of the angiocath. Surfactant is administered in 3 to 4 bolus pushes, each over 30 seconds, allowing time between pushes for the infant to recover and continue breathing. Elevating the head of the infant can help minimize reflux. The nasogastric tube can also be intermittently suctioned to check for surfactant in the stomach. Once the final dose is given, the catheter is removed. Oxygen requirements can be titrated as needed, and vital signs should be closely monitored to ensure stability. In our center, we typically perform LISA with the video laryngoscope. The reason we prefer video laryngoscopy is because it's been shown to improve the success of intubation. This is the major reason we transitioned from direct to video laryngoscopy. Another reason is that video laryngoscopy allows the entire team to see the airway during the procedure, so everyone has a shared mental model that the catheter went through the vocal cords and is in the correct position. A real benefit for us has been the introduction of the new Miller 00 blades, which make the procedure much more feasible in very small infants. Since adopting video laryngoscopy, we've seen improvements in both technique and overall success. So during the years that I've been a neonatologist, I've seen a significant change in practice. When I trained, we would intubate patients and give them surfactant and leave them on the ventilator for sometimes days or weeks. Now with LISA, we can provide in and out surfactant in minutes and allow the babies to continue to spontaneously breathe on CPAP. We found that less invasive surfactant has really improved the care that we can provide to patients. And the use of video laryngoscopy improves our success rates, as well as creates a shared mental model amongst the team that the technique was done correctly. I hope that this demonstration was useful and that you can apply these techniques at your own center.